This is a very common type of picture. So there is a big enlarged node here on the CT scan. This is the base of tongue and tonsillar area, so base of tongue more so than tonsillar area, but this looks actually completely normal, right? When you do a PET scan, this is actually where you find the primary. Here's the primary in the base of tongue. So PET scan has been extremely helpful. So as I said, these are younger, healthy, fit patients, and these are my present patients. And I've never seen this guy, but, you know, he's done a lot of actually to promote kind of just awareness of actually what's going on with this type of cancer. So one case history, I just saw recently this 42-year-old female, and she was previously healthy. She works at the airport for Air Canada. She's an engineer there. And she went to see her GP with enlarged neck node. And she was otherwise completely asymptomatic, and the ultrasound was done and showed 3.5 centimeter lymph node. And by the time when she went on to see her ENT doctor, she already had bilateral lymph nodes. And the fine needle aspirate was done, and this was squamous cell carcinoma P16 negative and a normal ENT exam. So it completely makes no sense. And we did a PET, and she does have bilateral nodes and asymmetry in the base of tongue. And then we also took a careful history, and she does have cervical dysplasia in 2003 that was treated, and now she has normal pap smear. So even though this is P16 negative and FNA, this is probably false negative result, and I stage her as a clinical T1 and T2C base of tongue squamous cell carcinoma, most likely P16 positive. So why am I kind of dragging this P16 story? So this is her base of tongue, and these are the bilateral lymph nodes, and this is how usually they look on a CT scan. They're quite cystic. So does it matter? It really actually does matter for us. So it's helpful for us to identify the site of the primary tumor, right? And so if we can't see so when we treat these people with radiation, we have to know what to cover with radiation. And so we cover the disease that is visible on the imaging, but if nothing is visible on the imaging, we still have to cover the possible primary sites, which really are tonsils and base of tongue. So also, as I just mentioned, really help us in delineating our treatment volumes. Also help us really estimating the prognosis for these patients and telling them how likely are they going to do well or unwell. Help us with the follow-up to know whether we should be looking for the mets or we should not be looking for the mets, or do we expect them or we don't. And also there's a proposed new strategies actually for treatment of oropharyngeal cancer because they're quite sensitive to chemo and radiation. So we maybe we can be even less offer less intensive treatments with the same chance of success. So this lady got, she's just going through her treatment. She got 7 weeks of radiation, daily treatments, Monday to Friday, weekends are off, and then every 3 weeks she has a concurrent cisplatin. And this is just how radiation fields look like. These are her nodes, base of tongue with a very high dose of radiation, 70 grays, and this is the dose of radiation that's covering kind of rest of the neck nodes, and here you see up to like 50 grays, the rest of the neck and rest of the base of tongue. So when we look at the outcomes of these patients, what we do notice is that HPV cancers are very sensitive to chemoradiation. And that's really a part of the good news. And the stage for stage, the recurrence rate is actually less than a half rate of HPV negative cancer. So almost twice as many are actually cured. So this is just an interesting article. They look at one randomized trial. So they pull out all the HPV positive cancers, and these are HPV positive and HPV negative. Huge difference. And then they look at, when they look at actually P16 positive versus P16 negative, this curves gets even wider. And the reason is because I guess they're just trying to find HPV 16 here, but when you look at all the other HPV possibilities, and they're actually P16 positive, then the difference actually becomes even greater. And so if you look at overall survival, this is stage 4 disease versus stage 1 or stage 2 disease. They're all pretty much the same. While if you look at somebody who has HPV negative tumor, so induced by the smoking and alcohol mostly, so there's a huge difference between different stages, stage 4 and stage 1, while here there's really very little difference. So even though they have these bulky nodes, they actually do quite well. This is how we used to do radiation when I finished my residency training program. It was a huge fields, really kind of covering a lot of normal tissues. And if this was a tumor, a lot of normal tissue would have been covered with very high dose of radiation, and that's all changed now. So these are the new, just to illustrate how we can actually shape the radiation dose around a tumor and around the lymph nodes that we want to treat and spare the uninvolved normal tissue. So it is actually far less toxicity that we are causing for the patients. But in the recent years, we figure out that just like in cervical cancer, if you actually add chemotherapy together with radiation, it works much better and we cure more patients. So now we are thinking, well, maybe we are actually administering treatment that is maybe too toxic. Maybe we can actually not give them chemotherapy, or maybe we can give them some alternate systemic agents like cetuximab, or maybe we can even reduce the radiation dose. So this group of patients is, I think, now becoming a focus of intense research as to how to de-intensify the treatments to actually give them less side effects with hopefully the same cure rates. And then there is surgery. So at VGH we do have robot, and transoral robotic surgery is something that is just really coming into play, and there's a huge national trial that we are looking particularly into these HPV positive tumors, where the surgeon will go in and with robot actually dissect the tonsil and dissect the base of the tongue. And so here is Ethan Prisman. He's the only surgeon who is actually doing this at the moment, and here's a robot. And this was in Vancouver Sun, and so it's actually wonderful. I went to see one surgery. It's actually quite remarkable how minimally invasive that surgery is. And in the past, they all had manipulectomy to kind of get to the base of tongue. Now he just opens the mouth wide, puts the robots in, and just dissect what he needs to dissect. It's actually quite fascinating. And significantly less blood loss and possibility of avoiding tracheostomy and shorter hospital stay and fast recovery, and speech and swallowing is much better. So that's the robot. So the last issue is, my partner has HPV-related tumor, and am I at risk, and what should I do? So there is actually a really nice study that looked at exactly that question. So they know that many patients and their partners actually do have this enormous anxiety about this HPV transmission from the partners who actually do have the cancer, and so this study is kind of trying to address that issue. So they looked at 164 patients, and they looked at all of their partners, spouses, and there's 93 of those that were willing to come. So they did an oral rinse for both patients and partners and blood samples, and they asked them some questions about sexual behavior and whatnot. And this is what they collected from blood, and they looked at the prevalence of any oncogenic HPV, so all of these strains were looked at. And this is, I think, very interesting. So this is the general population, U.S. general population. These are the partners, and these are the patients. So any oral HPV was only found in 64% of the patients who actually had known oropharyngeal cancer. So it's not 100%, so it's 64, and 43 in partners. So very low, actually. And among women, it's only 23, but look at the males, 33. So huge difference between males and females.
2.3 or 23?
Sorry, previous, let's take a look, if I can. Okay, so 4.3, so these are partners, 4.3, any women partners, 2.3, any men partners, 33.3. So these are the healthy partners, and these are the patients. Okay, and this is the general population. So in general population also, any HPV at baseline is 4.3 for women and 14 for men. But if they have a partner, men who have a partner that has any oropharyngeal cancer, it's actually 33, so it's double. And that is to say that most partners of patients who have HPV positive oropharyngeal carcinoma do not have any detectable oral HPV DNA, suggesting that either that oral transmission is rare, and or most partners effectively clear any active infections to which they're actually exposed. So really no significant worry. And again, this fact about women, perhaps women are exposed more often and they actually create better immunity to HPV than do men, and so that's what we see. But this is, again, actually quite a murky picture, and I'll tell you why. So just another point, that what you should tell your patients, if you have a female patient and her husband partner has oropharyngeal cancer, then the female partners need a pap smear testing for sure, and then after that first pap smear, they need to just continue as a general routine pap smear testing. So that's the only thing that is actually needed. And a recent research also suggests that husbands, so women with cervical cancer, have approximately 2-fold increased risk of tonsillar cancer, and that also supports oral HPV transmission by performing oral sex. So it's also interesting that only 61% of all the patients actually have oncogenic DNA detected in their oral rinses, which really suggests that there is a moderate sensitivity and low specificity of this oral HPV DNA detection for oropharyngeal cancer. And partners have cleared up any oral HPV infections they may have required within 1 to 2 years. So screening challenges, and so there's your brush. We talked about this and heard a lot about cervical screening and anal screening. So here's your brush, and so here's the cervix or maybe anal canal, and you can kind of scoop up these cells, right? But it's harder to sample the lesions in tonsil. So this is a tonsil lesion, so it's sitting in the crypt of the tonsil, so you can't really have an access to it. So it's not really pap test equivalent, so that's why it's a bit of a problem. So what is the alternative detection method? There is a saliva-based test for oral HPV infection. It's now available. I don't know much about this, but it's, again, unknown efficacy to predict lesions that are actually at risk. And then maybe we need better imaging technology, but that hasn't really been developed yet. So it's really, this is a bit of an in the dark when it's in the tonsil and the base of tongue. You can't quite see it, you can't sample it, so you're a bit in the dark. So what about HPV serology? It is available. It's type specific. And as we said, 70 to 80% of the population is infected at some age, and only less than 20 of unselected population is actually seropositive. So 80% are actually have negative serology. Now, the presence of these antibodies, if you're seropositive, the presence of antibodies doesn't tell you whether you've met the virus and cleared it, so it's gone, or you have actually persistent infection. So it's not clear what to do with these results, right? And patients only develop antibodies if the virus gets into the basement membrane, but not if infections are located in more superficial layers. So again, a big question mark what to do. And not all patients with persistent infections actually have antibodies either. So it's a lot of work that actually needs to be done. And vaccination is at this stage probably ineffective, but maybe it is actually effective, depends on which vaccine do we use. So I would just finish saying that in head and neck oncology, we do hope that people get vaccinated. And so we're not only going to prevent cervical cancer and penile cancer and anal cancer, but really we're going to see significant, hopefully significant decrease in oropharyngeal cancers. But that's next 10, 20, 30 years from now, probably. Yeah, I'll be retired. I think we should, absolutely. So this is another argument to actually, yes, vaccinate the boys.
Wow, that was very interesting. Thank you. Any questions for Dr. Keith?
I have a family of patients that have had oral pharyngeal carcinoma, and the mother had it twice and one of the sons has died of it. Should all of those family members be vaccinated, do you think?
I am the worst person to actually ask. I sit on the other end of the spectrum.
Right.
I just treat these patients. I'm not involved in vaccination, but I would say yes.
And does
That would be the most logical to me.
report typically say if it's P16 positive?
We ask for that staining to be done, and it's usually done, but it can be false negative of just, I illustrated that example.
And in my...
It's more like the whole clinical picture, and if I really wanted to go after this, I would have asked for core biopsy, and core biopsy would have been positive, but I didn't want to traumatize the patient.
Do you see any predominance of these cancers in Scandinavians? Because in my little practice, I have 4 Scandinavians who have had this, and I sort of wonder.
I think there was one study and looking whether it's more prominent in Scandinavians, and the answer is actually no.
Oh, it isn't? Okay. Thank you.
My helper to ask about the WebEx. I don't know how to do that.
There's a question over there.
Okay.
Just a question of clinical presentation with the lymph nodes. Which chain is it? Have you seen, is there a pattern, submandibular or?
It's usually submandibular and jugular digastric nodes, so upper neck, because that's really the first echelon of drainage of the tonsil and the base of tongue.
And they're fluctuant and?
They could be fluctuant, they're usually painless, and they usually kind of enlarge actually quite quickly. Some of them do have sore throat. I don't want to give you an impression that this never happens. Some of them actually do have a sore throat, and there's something is kind of itching at the back of their throat. The swallowing is different that they have, but it's most commonly they don't have anything else, just nodes.
Hi, any question from the people joined by WebEx? You can unmute your mic now and ask question. Sign it again. Thanks. Yeah, we have about 4 people. Yeah.
All right, thank
Okay,
you.
well, thank you
Thanks.
very much. I think we're going to have a coffee break now, right? Yeah.
So there's coffee and tea and
So we take a break now, and we'll be back in 10 minutes. Thanks.
This is hot. Where'd my helper man go? I don't know if my mic is on, but I get you to take your seats, please. Turn the mic on. It's on? Okay. Great. Well, I'll get us to take our seats, please, for the second half of our program this morning. Our next speaker, I have the pleasure to know professionally and personally. I'm her daughter's vaccinating pediatrician, and that little girl's really well vaccinated. Haven't given her HPV yet, but she's only a year of age. So Dr. Malhotra is a certified menopause practitioner, good to know, and a family physician with extensive training and expertise in women's health and university program development and improvement in Canada. She's the former director of Options for Sexual Health, otherwise known as Planned Parenthood. Dr. Malhotra is the creator and program director of a women's health residency training program for family practice residents here at UBC, and the founder of provincial HPV program through Options for Sexual Health. So very nice to have you here today.
Thank you, Jane. So my talk today is going to be, I'm hoping, interactive. What I want to focus on are those hot questions that come at you like landmines when people come into your office and they say HPV, and then it begins and it's like pow, 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 and you sit there going, well, why did I bring this up? And you want to in your heart of hearts, and you believe that it's the best decision for your patient, but that conversation is so awkward sometimes, so challenging sometimes, and you often get painted into a corner saying, I thought this was a good idea, and it ends up being a very difficult conversation. One of the more common questions that I hear is, I've actually never heard of it. And that is unfortunate in this day and age, but it's still happening in great array. So just remembering to step back from the doctor's shoes and remember that the general population doesn't always hear everything we're hearing in great masses. There's not a lot of media in Canada as far as medications go in comparison to the States. So at times, our patients might be a little bit behind in what they're hearing in media. So remembering to just backstep a little bit, remembering to tell them, there are vaccinations for this disease, and this is what this disease causes. So in simplified terms as much as possible. Remembering to mention that it is for both sexes and that it is really all age groups, all people. I try to make things as commonality processes for people, because when people come in and say HPV, no, not for me, doesn't apply, we have to be really clear to say it applies to everybody. It is a very similar conversation to something like HSV or just the common cold, to be honest. This applies to everyone. So we want to be really clear about that to everyone. We've already seen the slide. Being clear about the vaccines is also helpful, that we have come a long way in what we're able to offer people, and that hands down now we are doing highly effective coverage in what we are offering for people to have available to them, now having the non-valent vaccine, and how effective we are covering things. And I'm going to go through that in more detail as well. The key point in any counseling session for HPV is we can currently prevent cancer. And again, yes, if this was breast cancer, we'd have lineups out the street. If this was any other cancer, guaranteed, if this was a male-ordered cancer from the beginning, if this was started in male populations from the very, very beginning as a male disease, and we didn't bring colposcopy and cervixes and any of it into it, we would more than likely have a lot more funding, and we would more than likely have a lot more uptake to this process. But it's a hidden male disease, and it ends up falling on the burden of women. So we often get asked the question, why bother getting vaccinated if I'm getting regular PAPs? Now, this is an integral misunderstanding that the general population has and carries forward, and it is unfortunate. People in our population coming with this question fully believe that Pap screening is preventative healthcare at its best, but it's actually screening, and we have to differentiate that. It is absolutely preventative healthcare, of course, but it's not inclusive completely of what we can offer someone. So, yes?
I'd like to ask the opposite question. Why
Yes.
bother getting PAPs if you've gotten vaccinated?
Good question. Between Gina and I hope we can answer that by the end of this. So, when we talk about the division of care to the general population, we want to say we can offer you protection, we can offer you screening, and we can offer you prevention. All unique, all important, and all special in their own right. Condoms, absolutely important, not fully protective. Pap smears, vital, made a world of difference in our populations. But we know not everyone's getting Pap smears. We know that sometimes Pap smears are not perfect, and we know that we still have a long way to go globally when it comes to preventative healthcare with Pap smears. But really, prevention is a somewhat different role. Immunization is something that we have at our fingertips right now that is really prevention, not screening. It's not protection. It's all of it. It's not as simple as saying one or the other or the other. You've seen this slide already, I know, but I did want to still bring it up. When we look at what we're missing as far as Pap smears, it is minimal. Of course, we don't have a lot of people passing away from cervical cancer in, I'm married to an Italian, so I say passing away a lot in my life right now, pass away rather than dying anymore. It's a funny cultural thing in my world. But we look at the availability of access. I come from northern Saskatchewan. I come from a high volume of Aboriginal women who cannot access care easily. And I have a 70-year-old mother who flies around, who has people flown in for her primary care gynecology practice. So it's in my blood. I know these women are the few and far between in our population, but we need to focus heavily on this population. They are an important one in our province, in our country, and they are the ones that we need to be really passing on education to in strong and high numbers. Because although we have a wonderful Pap screening program for our woman in Kitsilano who comes every month wanting another Pap, we have to be very aware she is not our typical patient that we're talking about today. So remember to focus on prevention. Now this also goes to that woman that comes in from Kitsilano who says, I'm taking this vitamin and that vitamin and this vitamin and that vitamin to prevent everything, and wonders why you don't know about all of this. And you say, well, I do know about one thing that I can offer you for prevention that's very safe, very effective. And this is something that you can pull out and say, this is what I have for you. When someone says, I don't know anyone who's had cervical cancer, and should the government be using my tax dollars for vaccination? Now, this is a hot and heavy topic. A big reason is because of what's happening in Ontario. Has anyone been following what's been happening in Ontario? Our doctors in Ontario, our colleagues, are going to be suffering clawbacks in April. So they're going to get paid for the rest of the year and then have to pay back part of their payment from January to April. We don't know how much, we don't know what's going to happen, but it's to balance the health economy budget. So big deal, and it could happen in any of our provinces, but that is what's going on. So when we talk about what's happening with our tax dollars, how can we use it most effectively? Diane's already touched upon the fact that we spend a lot of money on colposcopy. We spend a lot of money on Pap screening. Could this be something that we could reevaluate? Could this be something that, yes, do we need to be doing so many Paps? Do we need to be screening these women on the rates that we are? In the future, maybe not, because what we could more effectively use our tax dollars potentially for is preventing the illness that this happened already, that this is leading to. It impacts a lot of women, there's no question, men and women. We see a lot of warts, we see a lot of dysplasia. Although we don't see a lot of cervical cancer and not high volumes and numbers are coming out of cervical cancer, we do see a lot of the other morbidities surrounding HPV. So they're high enough numbers that we are spending a lot of money towards. In British Columbia, for example, each episode of treating genital warts is around almost $600. So it's a lot of money. When you think of where the money is coming from and how it's being allocated, it's definitely something to be thinking about, because it's hundreds of millions of dollars per year. When we talk about how we could reduce costs to our system, really vaccination is the key in this particular circumstance if we wanted to talk dollars only. Vaccination in one study was actually shown to decrease our spending dramatically. So when we're spending $28 million on certain services to do with dysplasia treatment and management and HPV management, we can drop that down by vaccinating 20 or 30% more of our population by almost $20 million. So it's a lot of money. So we're talking a massive reduction in costs if we were vaccinating our population. When we look at the visits, when we look at the treatments, when we look at the repeat visits, and when we look at the specialty visits. And that is a government-funded program. When we talk about counseling, again, you have likely known someone who has had HPV. It is something that we want to reiterate to patients and parents. Anyone can say that. It's, of course, a touchy topic. We want to always be careful of what we say and how we say it to whom. But we want to reiterate to them that it does make financial sense to be vaccinating. So currently, we have a minimal number of people accessing the free programs. Not only do we offer it to very few people, but very few people are actually getting it within those programs. But if we were to increase the number of women, if we were to double and triple and quadruple the number of even just half the herd women getting the vaccine, we would more than half the costs to the system by including the payment of the vaccine within that cost. That's remarkable. What can we say that about if we were to spend just a little bit on these, that we could dramatically decrease the healthcare budget? It would be pretty special. Because we hear that a lot.
Mama.
So a sideline conversation, I get asked a lot. I'll have the mom and I'll have the daughter as the patient. I'm in women's health, for those of you that don't know, so I see the whole gamut. And someone will say, well, I'd like to get my daughter vaccinated, or I'd like to get my son vaccinated, but I don't think this actually applies. And that is sheer denial, as we all know. And how do you broach a topic about that? It's very, very hard. One of the things in the back of our mind that we should keep in place is something that Tin has brought up already. This is a Canadian study. It's the Pisces study that was done. We have a Canadian arm to it. When someone gets the result of having an abnormal pap or genital warts, there is documented clinical anxiety and documented progression of that over that diagnostic period of time to that person receiving that phone call. So it's really important for us to bear in mind that even though you might not think it's going to impact them, or they might not tell you that it's going to impact them from child to mom or dad or whatever the circumstance is, it's more than likely going to impact them negatively. Their future sexual behavior, their personal self-esteem, and of course, everything that comes with that. But it is documented that that is really impactful. When we look at the Pisces study, it's nice to see that this is a Canadian study. Although small, it is still important. We look at how long the issue lasts for the patients, and because genital warts episodes can last on average over 100 days, that is a long time for someone to be burdened with that anxiety and all of the things that come with that, the feeling of self-worth, all of the self-esteem issues that come with it. They're really important to bear in mind. And that's something to pass on to the parent, to the woman and man in your office, to say, you might not think this applies to you, but if it did happen, mental health is a big part of what goes in this disorder. So it is not just that we are treating the warts. It is not just that we are treating the cervix. We are also encompassing with our prevention and treatment the self-esteem and everything that person embodies about sex going forward. We want someone to have a healthy sexual attitude and a happy sexual life going forward. And if they say in their mind, my child's going to have one partner, they're going to have sex twice. They're going to make 2.5 babies, and they're going to move on with their life. In their head, they really believe that. I have a daughter. I believe that. I tell my husband all the time, she's going to have sex once. So it's ingrained in your DNA. But we also have to think, well, what if that partner came into the relationship and they hadn't had sex the one time, and they brought in the HPV, and then they got it? Okay, so be it. We're doctors. We can figure it out. We can do it all. But maybe they're mentally and emotionally traumatized about what has just happened. Maybe they've been traumatized by a colposcopy visit. Maybe they've been traumatized just by the repeat PAP that we take so lightly in our offices. And that's a big reason that there is a promotion not to have, not only the cost and all that we're doing, to having those young girls come to our offices and have these repeat PAPs and have all of this done, and the risk of having the younger population go through that and trying to start later. But it's important to remember that that carries through for decades down the road. So we want to keep our young people happy and healthy and safe emotionally as well as physically. So another question that we get asked, my friend had warts and they just went away. Very common. That does happen, absolutely. But again, a lot comes with warts diagnoses, and a lot comes with how long they last, and a lot needs to surround our counseling and our ability to talk to people about this. So again, self-image is a big part of this. We want to be very cautious to make sure that people are trying to get the best health and mental well-being that they can have. Absolutely, they may not stay around long, they may go away on their own, but isn't one day enough for someone? Like, how many times have we had people come in our office and it's something very minor, and they've been calling and calling and calling all morning long to try and get in for your urgent slot that you had available for someone that really, really, really needed it. And it was something to them that felt very important, and to you, it was like on the triage list, maybe not. But it's, again, we need to validate what's going on. And if we could have prevented that phone call, if they could have prevented that phone call in some way, and that day of anxiety and stress, wouldn't that be a good thing? I think it would be. And here's the big one. I've heard bad things about the vaccine. We all know that. We know the vaccine is safe. The global safety data is there. We've all seen it, we've all heard it, and we all know this. But even my mommy group is all doctors. All doctors. We had a discussion not that long ago. Is the hype real? Is the hype not real? And it was so interesting to see. We're all various specialties, so absolutely some pathologists in our group were like, I don't know, and that's normal. Like, how can you know everything about everything? But it's very confusing, and media is very good at what they do. So to twist and turn, especially since in Canada we get it secondhand very often. Something happened in the States, and then it trickles over to Canada, and so it gets even more confusing and more jumbled. So yes, the vaccine is safe. We have global safety data. We know that, yes, some people will pass out. It's happened in my office. It's happened in all our offices. Yes, vaccines hurt. My daughter screamed her face off at Jane's office the other day. Vaccines hurt. But very few people are going to have a real issue with any vaccine that we have on the market in Canada, especially one that is tried and true, like HPV. The tolerability of the newest version of the HPV vaccine is comparable to the others, so as safe going forward can be assumed. But then we ask, well, should I even bother? Is it even going to work? We all know that it's going to work. We know that we're achieving great efficacy with our vaccines, and it's passing that information on. Something that I find helpful that we've all brought up today is the Australian data. But a lot of people that have heard me speak before or spoken to me before know that one of the ways I like to bring this into my clinic is saying, like everyone knows, an Australian, we're in Vancouver or Whistler, likes them. They're a country like our own. It's not like you're saying, well, off in some far-off land, they're giving vaccine to everybody, and they have no problems and no disease. And they say, we're in this magical land Well, it's actually Australia, which is great because it's a comparable population that I think people feel a degree of camaraderie with. And if Commonwealth does nothing else for us, I think that's something great. But if ski work visas have done nothing else, this is helpful. We do know that the vaccinated population in Australia is doing very, very well. The numbers are petering out, and they can eradicate disease in our lifetime, which is pretty amazing. We do know that when the program began, no one knew what was going to happen, and the numbers that were so dramatically great really were quite a surprise to everyone. I think even Gina would have been surprised by the numbers. And, to happen so quickly, to see a decrease in disease within 6 months of a vaccination program was remarkable. Yes.
Were they using
Gardasil.
Cervarix as well? Or?
Gardasil. Was the main-
Gardasil. Okay.
Yeah. Really, all programs are at this stage. I believe the UK did for 2 years use Cervarix and then dropped it because the results are just so dramatic. And I don't want to diss on Cervarix. Cervarix did a great job at certain things, cost being a big part of it. So if someone had to get something, get something. But when we know now, especially having a vaccine like the newest, the 9-valent, where we can say, there is a tremendous difference in what we're offering someone, we need to keep that in mind. And that comes down to our standard of care.
Wasn't our government, though, giving, maybe I'm confused, weren't they giving Cervarix to people
Just
in
the
schools?
one-time program, not schools. That catch-up program, that one-time program, that was Cervarix. And that was cost. It came down to how can we get more people vaccinated. And absolutely, cervical disease is the disease of choice. So if we can get a cheaper version of it for needed times, it was necessary. But in the end, Gardasil is hands down going to provide the coverage that we need for warts, and Cervarix isn't. So does that make sense to you? Okay, go on. Oh yeah, no worries. So again, just highlighting the Australian numbers and highlighting to people that this vaccine is working and it's safe. And globally, if this vaccine was truly as dangerous as we've heard from Katie Couric and others, Australia would have probably alerted us at this stage, and we probably would have. So my goal today is just to embrace the practicality of these conversations that we're having with people and make it very clear that it's working, it's safe, it's being used everywhere. It's been used for a long time now. It's over 10 years of data. We have to really believe it. And then it's going to work for what it's intended to work for. It's not going to treat your foot fracture, but it's going to treat your cervix very effectively. One question we get a lot asked in our clinic is, I've already been diagnosed with HPV, so I don't need it. That is one of the most common things I hear. Not only do we hear, well, I'm getting PAP, so no big deal, but, well, and I had an abnormal PAP, so why bother? I already have HPV. And that's an important moment in time to tell someone, you have HPV, but there are multiple different kinds. And that's an educational point that doesn't take very long to counsel to, but just making someone aware of the fact that, yes, you probably had one strain, but the likelihood of you having all of the strains that are covered in the vaccine is highly unlikely. The original WHO paper that came out, gosh, now we're probably talking 15 years ago, in fact, in small print, on probably page 12 or so, those of us that took the time on Saturday night with our glass of wine to read it all through, had a moment in time in it that could have been highlighted much more effectively going forward, which said straight out, if you had HPV of one strain, you are still a candidate for this vaccine because you're unlikely to have the remainder of the strains. And that got lost in translation over the years by health professionals, by the general population, by everybody. And it's something we need to bring back into the discussion. And that's why at colposcopy clinic, you are now walking out with a prescription. The Patricia trial is one that highlights that very point, that our vaccinated group does better going forward even after abnormal PAPs. But this trial I really like. It's a small trial, the Kang trial. I know I bring it up a lot, but I like it. It's an easy trial to understand where we had the patients who had leaps. So CIN 2 and 3, what do we do with those patients? So these are the really questionable patients in our practice. And what was interesting is the recurrence rates going forward in the vaccinated post-LEAP versus non-vaccinated post-LEAP patients. And you probably can guess, the vaccinated post-LEAP population did much, much better going forward than the non-vaccinated post-LEAP population. And King, in fact, came out and said, no vaccination after LEAP is an independent risk factor for recurrence. That's a really bold statement, but a really important one. So can we prevent this girl from going back to colposcopy? More than likely we can in many cases. So that's something to bear in mind. So when my patients come back to me after their colposcopy appointment, I like to have a very detailed HPV-focused visit. So I bring them back for a special visit just to discuss going forward and what that means. And I think that's important. So it's all the more reason to be talking about the vaccine at this stage. I'm too old for the vaccine. 25-year-olds in my practice are saying this to me. So keeping a copy of the NACI guidelines in my office is helpful, showing everyone it's not just me, I'm not just some crazy vaccine lady coming at you with all of these recommendations. NACI is going to support that up to 45, we have really good data. And off-label, you can go past that. There's no question. I have a menopause practice. I'm still vaccinating a lot of my women in my practice. Off-label. We have a discussion. We know what's happening, but I think it's important. A lot of them have partners who have either passed away, or divorces, never a partner, all kinds of new circumstances. And I think it's important to have the same discussion with them. Yes?
So recently in the talk about that, and there was suggested that even if you get cancer and you were vaccinated, yes, that you are somehow more likely to benefit from treatment. Yes. Do you agree with that?
I do.
I was not sure, but that was stated. So
I do.
That would be another thing to actually convince people, right? So even if you get it, you have better outcome if you need treatment.
Yes, absolutely. That's absolutely correct. What I find remarkable about HPV, you've seen us sitting here and all of us are talking to each other's talks and very similar information is being told to you. And all of us are saying the same thing. There's still a long way to go in our knowledge of HPV, but what we know for sure is vaccination is only going to cost you the price of the vaccine. So going forward, there's absolutely no population that I would say, probably not for you unless they were actively pregnant. And that's really it. And that's because we're not going to touch those ladies. So we're going to stay away from those ladies for everything. Really, age is but a number. And 45 is young. Like if we think about it, when we're 45, what's going on in our lives, that's a young person. Like 45-year-old women are coming into my office hoping to get pregnant at this stage. So, it's a totally interesting, arbitrary number in many cases. It's really based on how much data we have at each segment of life. You have heard about the vaccine protecting against more than one subtype. I do recommend not promoting the cross-protection data. It may happen, it may not happen. Just promote the vaccine for what it is meant to be promoted for and authorized for. So reiterating just the guidelines that Health Canada puts out, it's easy to keep these as a little chart on a wall in your office for people to read while they're waiting to see you, and then they can bring it up as well. Will I need a booster? We've discussed this earlier today. More than likely not. We're at just over 10 years now and still doing well. We don't have breakthrough cases, and that's what's going to tell us whether we need a booster or not. So we've got great immune memory. So we can't promise, but going forward, you're okay. Can I get another vaccine? I, as Jane knows, like to give as many vaccines as possible at one visit to my child. So arms, legs, whatever, will wrangle her down and wrestle her to the ground. But it's important to know that it is safe. You can concomitantly give more than one if that's what's happening. What are our patients hearing? Many things. Most of them that we are the devils when it comes to vaccine and we are all paid out of pocket by pharma. and that we are promoting it and making it in our back rooms and selling it for whatever we want. That's the bottom line of what's happening on Facebook. So we have to recognize the validity of that to people, in that many people, that's their news. They get their news outlets from Facebook. Gone are the days of pulling up a chair to watch Peter Mansbridge with your family and say, hey, that's the news. That's gone. Your Twitter feed and your Facebook scroll, that's your news. That is where you get valid medical information these days. So we have to be very careful to dance around it, because it's insulting to say to someone that's crazy when it is. But that's what someone's hearing, and it's on massive influx. The feeds are updated by the second, by anybody at all. Any author is now a reputable journalist. So we have to be really, really careful. Donald Trump is a doctor all of a sudden. You know, to say that I am now questioning not only every other normal thing on the planet, but I am also saying that the doctors are big fat liars. A presidential candidate in the lead is saying this, and celebrity goes a lot further than we do. And when you see there's a physician running for president now who also said something very, very similar, a neurosurgeon. And it made me very sad to see that you have now turned your back on your profession to get votes. And that's scary and really, really important to not be president, and really, really just sad. So to bring back these autism fears and what the doctors are doing and how much money they're making off of us, when I don't think anyone here is going to be ordering the brand new Tesla anytime soon in this room because of the money they're making off their pediatric and GP patients. But we're trying our best, really, just to get through the day and do the best we can. When counseling, we do want to offer some reliable sources. So diversion is a good method. It's often the only method. So saying, yes, I validate where you're getting your information and what you're hearing, but these are some sources I trust, and this is where I'm coming from. Something I do in my menopause practice as well, where we say, I understand what you're hearing, but this is what I practice. And that's all we can do. We can just keep our backbones. We can just keep going in our own right and go forward as we can. So there are a lot of great resources available to people, and they're Canadian websites or global websites, which is really good and easy to navigate. I find them very straightforward. When we talk about our boys, what to do, not only do we have the issue of coverage, but we also have the issue that we all know we don't see them. So they come in with their moms, and then we've never seen them again. And that's difficult. So the approach that I'm taking in my clinic, and the floor is open, is to hopefully have the woman in their life try to navigate it. If it's a sister, or if it's sister-in-law, or a mother or grandmother, to give them the Kool-Aid to give to the boy. And so I don't know what you're doing in your program, in your clinics that has been successful. That has started to work, where people have asked, where does he get the prescription? I will make him do it, kind of discussion. I will at least bring it up at the dinner table. I will at least go forward. If there's anything else that's working for people, please, the floor is open. So it's a tough one. The things that we can do is that we need to be a team. We need to have a strong front going forward in medicine. It's really important. We need to be verbal. We need to bring the conversation up as much as we can. Every time we see someone, we need to be bringing up the things on an ongoing basis. You can't bring up everything at every visit, but serially we can get through it, being confident with our message. So when we're being painted into that corner and they're saying, but what about this and what about this, and they pull out their phone and there's Donald Trump's tweets and whatnot, be confident. Stay strong, sister. Like, it's important. We don't have a lot of media coverage that's positive. So as visible as we can be, the better. So signs and whatnot in your office are important, because the doctor's message is still going to resonate to some degree. They can say yes or no, but it will be heard and felt at some point in their lifetime, which is good. They will know that we mean no harm and that we do want to help, which is good. But it's really just that positive message and being very confident in it. Questions?
That's great.
Thank you.
Boys are not getting it in school, are they?
No, they are not. I believe Alberta, PEI, and is there one other province?
Scotia?
Nova Scotia. Nova
And is
Scotia.
anybody working on that?
Yeah.
There's
Yeah.
one.
The hardest working woman in medicine is sitting right here. We're very lucky to have Gina here today because although we're fighting the fight, she is fighting the fight 24 hours a day. And there are a few people who work harder than she does in medicine in general. So we're very fortunate.
You talk about that yummy mummy from kids.
Yeah.
But she may be on supplements, but she's less likely to get her daughter to get HPV vaccine.
Absolutely.
There's a negative correlation between
She'll buy her
socioeconomic status.
condoms
Yeah.
and leave them in the jar at the front door, but no vaccine. Like, it's a real dilemma of
Like,
thought.
HPV will not
So,
cross over
yeah.
Maine, right? So
Absolutely.
I have a question.
Yes.
Has anyone figured out why the Fraser Valley is so low? Because if you look at the actual individual schools, like I thought it would be a lot of the religious schools, but
Yeah.
there's low rates in a lot of the public
Yeah.
schools. So is it a religious thing? Is it an economic thing in that? I don't know, I find a lot of the West End or the well-off are the ones that are really even more anti-vaccine versus the very poor people who come from third world countries. So
Yeah.
any idea why they're so low?
This is semi-opinion. There is an issue with my experience in the Valley with cost, with education, with the translation of media forward and what is being heard and felt and understood. There is a severe physician shortage for primary care physicians to get to the patients. And there is a severe lack of public health in schools. So there's multiple factors. I don't think it's one thing that we could pinpoint and say that's what it is, like we tried to do with the Bible Belt scenario. That's really not completely correct. But there are multiple factors that lead to this storm that happens. And it happens to be this pocket of care. It's not the only pocket in BC. There are other pockets. But it's a misunderstood area of care. And I think it does translate a lot to education in many degrees. A lot of third world countries will do anything to keep their baby alive because they've seen death. So it's very different. Like my mom runs a cervical screening program in Delhi, of all places. And in that program, all she's doing is buying pap slides and training a nurse. That's it. And they will come in droves, because they've seen people die. We haven't. So there's that. So it's an unfair comparison, I think, between the third world and our population because we don't see death. If someone gets sick, they're unlikely to really pass away in the same degree and in the same circumstances as a third world country. But our yummy mummies and kids, that's a whole other beast. Like that's a whole different scenario where they can access care almost too easily. Like there's almost like a drop of the dime type of scenario where they can get private care. They can access their physician 24 hours a day at times. And maybe that's not a good thing all the time. So each scenario is probably different. I don't know if Gina would agree, but I think each one's a different case. So, yes.
Is there any data with a 3-dose series, how much protection you get after the first dose? And
I'm going to leave that to her.
Oh, okay.
Awesome.
Okay, and the WebEx questions?
Hi, people joined by WebEx. Do you have any question? No? Okay. Yeah.
They all went for coffee.
Thank you.
Okay.
Thank you.
Thank you very much.
Thank you.
Very interesting. So our next speaker has a very long list of accomplishments here, but I'll just get the high points. So Dr. Ogilvie completed her undergrad education at Queen's and then McMaster, did a family practice residency at McMaster, then a fellowship in population primary care at McMaster, then came here and did, where did you go then? Oh, master's in UBC, and then a doctorate in Northern Carolina, Gilling School of Public Health. Her clinical and research interests include women's health, care of marginalized and at-risk populations, reproductive health, sexually transmitted infections, HPV screening and HPV vaccine. She's certainly very widely published in these areas. Gina is now Canada Research Chair in Global Control of HPV-related disease and cancer. And she is principal investigator of the HPV focal trial, a randomized trial covering over 30,000 women to examine HPV testing versus cytology as a primary screen for cervical cancer. Thank you for coming this morning.
It's great to be here. That was a great presentation. Thanks, Anjali. That was wonderful. So just quickly to answer the question about one dose. So the data is not, there's one study from using actually Cervarix that really looks at a single dose, and it actually offers some protection. But there are actually now planned about 3 trials globally to look at a single dose. So I think, that is likely where we're heading, to single dose of the vaccine. So, and potentially even single dose at 11, and then single dose at 25, and if it's doesn't sort of achieve the sort of immune level we want, and then you're done. So it's a very exciting time, for sure. But for me anyway, it's exciting. For others, it's whatever. I think you guys also nailed. I do want to be really clear. The sense that you guys have that the more educated you are, the less likely you are to get vaccinated is spot on. That definitely came out in our analysis of women, when we looked at parents of kids who received the HPV vaccine in the province. So these were actual people who got the vaccine or not, and one of the biggest predictors was socioeconomic status inversely. So the more educated you were, the less likely you were to receive the vaccine. I think there are a couple of things in that. Google University, people feel they can go online. I do think, physicians, often we fall into this. We're smart, we're book smart at school, so all of a sudden we think we're great financial gurus. And that's why there's MD management, because so many physicians lost so much money in the markets. But, hey, we're smart at school, so hey, we must be able to do that. So I think it's the same thing in other ways. I have a lot of parents of children I know who, they have a PhD in history, and so they feel that allows them the same level of expertise, and they are very smart, don't get me wrong, but they feel the same way that physicians felt our knowledge translated to our ability to be sort of market gurus. Same way they feel their knowledge allows them to be, science, leading scientists. It's the same sort of mismatch. And I think the other thing, actually, to be honest, is I think people who are wealthier feel control. So I don't need to get it in grade 6. If I choose to get it in grade 9, I'll take my child to the public health nurse, or I'll pay for it. I don't need to be managed by the public health system. So I think there's a couple of variables, but I do think the most dangerous one is folks feel they're able to do their own research, and we know what it is like online. So you're spot on. So today what I wanted to do was give you guys, when we talk a little bit about PAP screening, I want to just talk a bit about the future of PAP screening. As people who are focusing on care of children and pediatrics and adolescents, I think the bottom line for you to know is that as we move forward, PAPs will be less and less of an issue, certainly for youth and likely for women. We will be sort of transitioning to a whole new way of screening. But I think it's really important to know that the two dovetail together, and that there are factors, particularly the HPV vaccine, but also the technology we're using will actually now change also the type of screening we do. No conflicts. So you guys have all seen this, and I think the big thing that is important about the natural history of cervical cancer is we ultimately would love to protect, and Anjali talked about the fact that people say, well, PAP screening is good, but the best thing obviously to do is prevent acquisition, so that's why we want to work here. But PAPs work here, where we want to detect precancer. And I'm going to talk about, hopefully, where we can detect here with HPV infections. Interestingly, as good as PAPs are, there's actually never been a randomized trial to show that PAPs work. They were introduced as a sort of a smart move, but they've never actually undergone a clinical trial. So I always find it very amusing / depressing when you do read those sort of op-ed pieces where people say, well, Pap screening works great and there's good rigor in Paps. I agree that Pap screening work. Here's some great data from the UK showing that once they had an organized program, we saw a reduction in cervical cancer. But let's be clear, the rigor of Pap screening versus the rigor of HPV vaccine actually don't match. HPV vaccines have been far more examined. We have far more knowledge about adverse events from HPV vaccine than we do from cervical cancer screening with PAPs. This is not meant for you guys to delve into detail, but I think what's important to note is that there is variation across Canada. It's the joy of our Constitution that gives us a public, that puts healthcare in the hands of provinces. So we do have differences across provinces. The big thing for BC is to know that our current Pap screening guidelines are that they start at age 21 or within 3 years of sexual contact. That's been a bugbear for many of us, but theoretically, right now, if a young woman is sexually active at 15, she should be having a Pap at 18. I do want to flag for you that will likely be changing, but that's where we're at right now. So what's the future? Well, to be very honest, the future is HPV screening. So this is some data from pooled studies from actually Finland, some places in Europe and in Montreal. And what it shows is that when you have screening for cervical cancer that includes an HPV test, this is not exclusively only an HPV test, but includes an HPV test. When you follow women, using that HPV-based screening reduces not precancerous lesions, not colposcopies, but actually reduces cancer. So when you actually include an HPV molecular test in the screening, and it prevents about 30% more cervical cancer than cytology. So it's a very important finding. This was a pooled meta-analysis. And there's the data just showing again that the reduction with arms that included an HPV test. So this is what we likely will see in the future for cervical cancer screening, which is we will start between the ages of 25 to 30. And again, I want to give you the global landscape just to remember the UK starts at 25, Holland, Netherlands start at 30. So our programs in Canada start much, much earlier than other jurisdictions. We will, yep.
Hasn't the Canadian Preventative Task Force said 25 as well?
The task force has, but that hasn't, no province has actually used that. And there's some debate too from the task force because they were reluctant to push for HPV screening, and so there was a lot of hesitancy around their findings on that as well. Yeah. So where we'll likely see is we're going to be moving to a start age of 25 to 30, 20, depending on how comfortable health agencies feel, maybe 21 and 22, maybe. But if it's HPV based, it won't start likely till 25. 25 to 30, going up to 64. We will see an extended, so that's a big thing for if you have a youth practice. You won't routinely be offering cervical cancer screening. And remember, screening is for asymptomatic people. If a young woman has symptoms that you're concerned about, bleeding PV, etc., you're still going for your diagnostic assessment. So let's make sure we're really clear that screening is for people who are asymptomatic. So, and in those young women, in those women who get a screen and are negative, so normal, we probably will extend out the interval to 5 years. So a very different approach than many of us are used to with the annual or biannual PAP. For women who are positive for HPV, we'll likely do what's called some type of reflex test. And I won't go into all of the details of that, but that will be done at the lab. That's not something women will need to come back for. And it'll be an additional test to help improve the specificity. HPV tests are far more sensitive than cytology, but they're much less specific. So what that means is there's an issue of actually iatrogenic illness. We may be over-identifying certain women who don't need to be followed for colposcopy.
Would this be a blood?
No, so this is all on PAP, all like the PAP smear. It's sort of like taking an STI test. So what we'll do is a reflex test, whether that be a molecular test or on a liquid-based specimen, just a cytology. And then those women who are HPV positive, cytology positive, they'll go on to colposcopy. Women who are HPV positive but cytology negative, they'll go into a more frequent repeat screen so we can monitor if they start to develop persistent infection, precancerous lesions, etc. So I just want to give you this, sort of a work in progress, I would say, but just so you have a landscape of where we're going to be in the future. So one of the big things that I just mentioned to you that we had that big meta-analysis that looked at HPV based screening, let's call it, so screening that had HPV. In BC, we took the step of actually doing a randomized trial comparing just HPV screening. So not HPV with a PAP. We just did HPV screening and compared it to cytology. This is called the HPV focal trial. Just so you have a sense of it, we are looking actually for CIN3 at year 4. And I know everyone's saying year 4, but you said it was going to be a 5-year interval. I do have to tell you, this field really moves rapidly. When we started, you can see the next objective, our ethics board said, we think 4 years is too long, so you need to put in a 2-year arm. So from then to now, where we're getting criticized, oh, you should have randomized a 5 and a 10-year arm. So it's very interesting how even in a very short period of time, the field has moved so quickly. So our main endpoint is looking at precancerous lesions in 2 arms at year 4, post-screening. So it's a large trial, about 33,000 women, and then we have an initial round and then a second round or third screening round, depending on their arm. CIHR funded, and funding was approved for 7 years. We've long spent all that money, by the way. We're getting other money. So the big things I want you to look at here are the control arm and the intervention arm. Don't worry about the safety arm. The control arm, women get cytology, and if they're negative, they get a cytology at 2 years, and if they're negative, they get a cytology at 4 years. The intervention arm, women get an HPV test, and if they're HPV negative, they don't get tested for 4 years. And that's what we tried to do, was mirror what we thought the program would look like. So this is all embedded in the cervical cancer screening program. These women have all of this data within their cervical cancer screening history. So that was really important. So that's the main outcome. If women are abnormal, I won't go through it in detail, I'll just show it to you. There's an algorithm that we go through, whether they go to colposcopy, etc. But the big things for you to know is this. We're comparing regular cytology at 2 years and 4 years for women who are negative compared to women actually getting a screen every 4 years. So we've got 25,000 participants enrolled, 18,000 have been discharged from the trial. About 500 have been discharged because they actually had colposcopy, and we anticipate all screening will be done by December 2016. So just a very busy slide, but what I just want to show you is that the round 1, so the first screening, not surprisingly, HPV detected more precancerous lesions. HPV we know is more sensitive. We're not surprised. We detected more precancerous lesions. And that's both in under and over 35-year-old women and overall.
That's really delicious milk.
But HPV screening resulted in almost double the amount of colposcopy referrals. So we do have an issue that we're going to have to manage, which is that we have more colposcopy referrals. And so we'll need, probably what we need is a better test to discriminate HPV positive women who truly need to go on to colposcopy versus just sending women who are both HPV and cytology positive. We probably need something else to help us be a little bit more judicious in that. And we're excited because this has been named one of the most important sort of trials for cervical cancer screening globally, and will be helping to set the stage not only for Canada but for the US, who, as you know, have a long history of way over screening everyone for everything. And so they're really looking forward to sort of getting some really rigorous data to show not only whether we prevent cancers, but what the iatrogenic consequences of over-screening are, and are we actually doing harm to women if we, for instance, too frequently screen them with HPV. So I wanted to really focus for this group a bit about the age under 25, and how many of you have youth practices where you're doing youth clinics, or are any of you in that group? And yeah, Anjali's. Yeah, so this has been actually quite a concern, I find, particularly for the public health nurses, more so than some of the practitioners, but particularly the public health nurses who've worked with youth clinics, the sort of 15 to 20-year-olds, and many of the nurses who've been doing this for years. And we all have seen a CIN2 in a 19-year-old. I mean, if you've practiced long enough, we've all seen it. Now, sometimes I feel like it's the same case that we've all sort of helped to manage, because we all manage in teams, but we all have seen that. And so there has been a lot of concern brought forward to me about, what about this under 25, that we're not screening women under 25? And I think we have to be really careful about what screening is. And remember, we're screening to help us improve detection and ultimately improve the outcome. Just because you detect something doesn't necessarily mean you improve the outcome for that young woman. So we all know about lead time and length time bias, and those are really important in this age group, because if you go all the way back to that first slide I started with, remember the natural history, right? You acquire HPV, then you develop a persistent infection, then you develop a precancerous lesion, and then you go on to cervical cancer. So there is, by and large, a long natural history. So whether we detect it at 19 or 25, the risk is that many of those may have regressed, and that is a natural history consideration, that these lesions do regress. So are we over-screening these women? And then particularly in young women, and many of you will remember this, when you do a PAP in a young woman, I mean, the sort of transition zone and the metaplasia is just massive. So if you send that woman to colposcopy, what happens as a colposcopist, we're taking out a huge chunk of your cervix. And there is data that shows that if you are doing LEEPs and excisional procedures in younger women, it is associated more with preterm labors and low birth weights. And that makes sense if you don't have the same type of tissue present. So we have to be super careful that not only are we detecting what we want and preventing what we want, that we're not harming these women more than we intend. So let me just show you some of the data. This is always the stark sort of reality, and to Anjali's point about parents and the HPV vaccine, I have about 3 vignettes in my head of a nurse who I worked with who was very interestingly anti-HPV vaccine, and she was telling me all her reasons. And I take the stand like you of listening and of saying, that's not my experience of the data, and I try to articulate it. But I also feel that it's important to not close the door, so I leave a very open sort of dialogue. So she shared her thoughts with me, and I gently disagreed and said, here's why I don't believe it's right. But she had a 15-year-old daughter, and she wasn't going to get the daughter vaccinated. And I said, well, isn't it great we're in Canada and you can make that choice? What else am I supposed to say? Like, super. I didn't think that was a long-term solution. Jane's suggestion was I say you're an idiot, and I'm like, oh, well, I know how Jane practices. I know that never happens either. So we all think it that way. So I just left it. And then, we're chatting, and it was the weekend. And, okay, have a great weekend. And I swear to God, I'm not kidding you. On the Monday. So just remind me, if my daughter missed it in school, how would she get the HPV vaccine? I was like, well, that's curious. You go here today. She didn't know. Her daughter had a boyfriend for 6 months. They had been sexually active for quite some time. And it was this boom. And it's back to that point of, and it was all of the rise above, noble, good person you are. Oh, let me help you. And just, it was all I could to not say I told you so. But that is, so I'm telling you guys, I told you so. I wanted to say that for so long. But I think it's not an uncommon experience. As the parent of teenagers, I get it, right? There's a whole world that I'm not part of, and that's the nature of the beast. And so, I think when you're sort of at the population level, you can understand that, 30% of 16-year-olds are sexually active. Like that's the data in BC. You know, that's the data. And by 19, the vast majority have been sexually active. So that's just the data. So I do think, and this is the data that confirms that. If you look, these are young women who presented for reproductive health, and you can see the prevalence for HPV it's almost 35% in women 20 to 24. I mean, it is very, very high. But remember the natural history. Most of these are going to resolve on their own.
We'll go pick up Mama.
And here's the mirror of it. So we have, here are the cervical cancer rates, actual cancer rates in young women under the age of 25. And you can see these rates fall well below, particularly for under 25, what would be the justification for any screening program. Okay? So we have to be really, so remember, a screening program, and this is the harsh sort of conversation, a screening program doesn't promise to find every case. It promises to find most, right? And so we have to be careful we don't design a program to find every case, because if we do, we will do harm to those women who shouldn't be in it. Yeah.
Could you, on that sort of vein, comment on doing PAPs in women over 65, which many countries don't do?
Yeah, so it's the same. So we will get, so the question was about doing PAPs in women over 65. And again, Canada's in this really interesting, because we do have more European sensibilities, but we're proximate to the US. So we have this bizarre kind of where we're influenced. So a lot of our healthcare practices are influenced more by the US. Like you said, in Europe, a lot of the countries actually don't screen after the age of 65.
But I'm actually an American doctor, and we stop at 65. I don't understand this Canadian 69.
So it depends on which guidelines you look at. So ACS says one thing, ASCCP says one thing, US Task Force says another thing. So this is, and most of the specialists lean to whatever they don't go to US Task Force, they go to whatever their specialty journal says about it. So in Canada, we have continued to 69 because one thing is our immigrant population. So we have a large number of our cases in the 70-year-old cohort are actually women who actually haven't been screened all the way along. Anja, you talked about the sort of, and if you look at BC, for instance, our two largest immigrant populations are from Asia and South Asia. Many women will arrive having never been screened. So what we have to do, where our guidelines will go, is we will stop likely at either 59 to between somewhere like that, if a woman has 2 to 3 negatives on record. That's going to be the key. So they have to have negatives. If you don't have negatives, you keep going. And certainly you have to also remember in the future, our women who are immigrants as adults will not be vaccinated against HPV by and large. So they're going to need to keep screening. So yeah, it'll be based on frequency of screening. So that's one thing to sort of reassure you. And let me be clear, I suspect when we go to our HPV-based guidelines, we will likely still allow women under 25 to be screened, but it will likely be done with cytology, I suspect. So we'll start HPV at 25 and sort of offer, I don't want to say offer screening under 25, but it won't be turned away, if you know what I mean. Yeah. And here's the thing I think that's really important for you to look at, is you can see that regardless of the presence or absence, this was from Finland, regardless of the presence or absence of a screening program, there was no change in rates in cervical cancer in women 20 to 24. So Finland didn't have a screening program, then it had a screening program, and you can see that throughout the entire period of time, the 20 to 24-year-olds did not change. So that's really, we're not, for those very rare cervical cancer cases in that age group, PAPs are probably not the way to diagnosis, and neither is HPV. They probably just have a very unique natural history. So I do want to just, I know I've got a few more minutes, I do want to end off with just a few comments on, remember the difference between screening and case finding. And if someone has symptoms, they need to be screened, they need to be assessed. Women still need reproductive health screening, and particularly for adolescent women, 13 to 25, they still need their STI screening, their reproductive health, their contraceptive counseling. So you don't, just because you're not doing a PAP doesn't mean those other things don't need to happen. And we need to support access and uptake of particularly reproductive health screening and ongoing monitoring as needed. So what are the implications for HPV testing for clinicians? I think I've just showed you that strong evidence is accruing that HPV-based primary screening will detect more precancerous lesions. The increased sensitivity will result in less frequent screening, a later age start, and earlier finish of screening. But the poor specificity will result in increased colposcopy, likely at the start of the program. So I think some questions for clinicians is how do we continue to engage women in routine care? And, you know, one of the things I remember when we transitioned, it used to be when I practiced, we wouldn't give women oral contraceptives if they didn't have their PAP. And then all of a sudden we realized that's like totally unethical. Like if they don't want their PAP, that's their choice. And it's the same thing here. We have to divorce. We can't say, well, we need to keep some type of cervical cancer screening because women need to come in. What we need to do is a better ability to engage patients. Frankly, I think in the new world with social media, texting, email, you're actually able to do some very important push technology to get women to come in for their routine testing. So we really need to just think of other ways to engage women. So there's certainly a continued need and for both reproductive health stuff, but also the general health screening that women need to have. And just some considerations for implementation. This is from HPV Focal, where, as I said, we've over, 20,000 HPV screens, and we've talked to a lot of women. So women are very concerned about the extended intervals. So one of the things I hope when you're talking about extended intervals and later start dates, you can understand the reason why we have the extended interval is actually because of the improved sensitivity. Lori Smith, who's been the program manager for HPV Focal and has talked to a lot of women over the years, has a great line. She says, now, PAP screening started out in about the 1950s and 60s. Do you have any appliances in your house from the 1950s or 60s? And people paused, and she said, yeah, no, that doesn't mean that fridge that your mom has in the basement that makes a lot of noise and you can't, open the lever. It doesn't mean it doesn't still keep food cold. But do you want that fridge? Or do you want the fridge that's temperature controlled and can do it? It's the same thing. We're not saying PAPs aren't functional, haven't done a great job, but technology's moved along in virtually every other field. So the same way you don't have to defrost your fridge every 6 months, we don't have to screen you as frequently because it's a better test. So that's I think a very helpful. Lori's done a lot of this, and she came up with that one. I was like, that's the one. A new test. So you alluded to new tests, guinea pigs, trying new things, and I think it's fair to say that the Hans Kruger won the Nobel Prize for this. So for finding HPV. So it's, I think, pretty legit crew would be my suggestion. Certainly, the HPV transmission is an STI. I've been a doc working in STIs for years, and I won't go into it at length here, but I think one of the things I'm very careful about is doing exactly what Anjali talked about, being proactive. Why are we getting this test? We're not getting it for STI diagnosis. We're getting it for cervical cancer prevention, so we're going to work forward with that. In general, my overall advice is don't get trapped into what I call STI CSI. I don't know where you got it. I don't know who gave it to you. I don't know if you gave it to your partner gave it to you. I don't know if you got it. You know what? I actually can't tell you. To be truly honest, what I can tell you is this is here, and let's move forward and we can act on it. But I can't tell you if you've had it since that one night in college, or if this was something your partner has had for a long time, or if you just had a low copy rate and now we detected it. Like, I don't know. And it's actually not fruitful to try to spend a lot of time trying to sort of figure that out. So that I think that's a rabbit hole that just is not productive. What do I tell my partner? Usually partners, if you've been sexually active, already have it. So it's a sort of an ongoing conversation. You can talk actually about vaccination. You can talk about some of the issues around reoccurrence, but that's a sort of longer conversation. And those are the few of the questions we've logged. And then healthcare practitioners, the practitioners are also worried about the extended interval, as I mentioned, the time it takes to educate and inform, not having, because it's such a dynamic field, sometimes there's so many things a generalist practitioner has to know that it's hard to keep at the forefront of everything. And whereas if a patient is totally obsessed on one topic, they can drill down. So that's one of the things. So we can actually work to make sure folks are really well prepared. Billing and how you bill for it, not knowing how to counsel women with positive results, where did I get this, when did I get it? So those are things we've been able to help practitioners with, and the implications of positive results. And like I said, we're doing this test for cervical cancer. We can actually prevent cervical cancer, so that's why we're doing it. And it actually, if you have an anticipatory sort of proactive lens to why you're doing this, it's actually very helpful for women. And it's our job is to really frame this as what it is, which is actually, we can actually prevent a cancer. That's very exciting and positive, and we're gonna manage this and actually prevent this from progressing any further. So I think with that, I will just say that we did have a central line, so we're working with BCCA to keep that up and to think about how to educate your patients prior so that they have a bit of knowledge when they come in. So I think just recognizing the time, I'm going to leave it at that. So I hope that was helpful.
Any questions for Dr. Ogilvie?
I'm going backwards on this. We have students who come that have had HPV-9 at a physician's office come, and we only actually sell at the moment HPV-4, like the Gardasil 4. And they want to go that direction because it's 144 and not 190, and they're going to go back home and get the Gardasil 9. Is that okay?
So this is where you're sort of getting in, we're supposed to declare when we go off-label recommendations, and Bonnie's here. So my thought on my answer to this, get the vaccine in their arm. So if that $50 is going to make a difference to them, there's no the vaccine dynamics are quite similar. So there's no sort of interaction harm. And in fact, Merck did a trial where they revaccinated a whole bunch of girls who had quadrivalent to non-valent. So there's not any safety issues with it. I mean, my druthers would be, yeah, if you've started the 9, finish it. But I get $50, particularly for a student, can be a rate limiting step. I want the vaccine in their arm. So if this is what I need to do to get this vaccine in their arm, give them the quadrivalent and the non-valent. What you can't guarantee are what the sort of ongoing longevity of those extra 5 types are going to be. You just can't guarantee that for them.
But you were talking about how they were going to give one potentially, and then X number of years give another. Yeah. So that's the question mark, because these are students who think read and whatever. So their question is, well, if I got one and I get this, and then if I get the last, then...
So let me just be clear. The data I'm giving you guys is kind of the forefront stuff. Right now in this province, 2-dose is only recommended for people under the age of 15. So your immune response once you hit puberty is so much lower. That's why we need to do a randomized trial for it. Yes, that's where it's going. Look, I gave my son 2 doses, even though it's not licensed for boys for 2 doses, way prior to it being licensed for boys, because I knew the science, I was comfortable with it. But that's not what the policy is. So I think you have to be really careful in those situations to also offer people what is the sort of standard expected policy. So, and certainly I think from my vantage, it really at 15, 16, you do see this precipitous decline in terms of their responses. So we do have to really be, when we talk about reduced dosing, it's largely in the under 14 crew.
So it's after 25 is one dose enough?
No, you press your things.
Okay.
Here.
After 25 is one dose, regardless if it is quadro or, higher one. Is it enough, one, or do you still need boosters 3 times?
So the current schedule,
At any age?
the current recommended schedule is 3 doses so our school-based program would be between 9 and 13. But if you are going to start a series at 25, no, they need 3 doses.
Thank
yeah,
you.
Yeah.
In terms of the children the adolescents not coming back for their scheduled doses, so have there been studies that show that 0, 6, and 10, and like what is effective, and when do you have to repeat the series?
So the policy in BC is just to restart the series wherever you are. So that's the policy in British Columbia. So if you've had 2 doses and you're coming back for the third, give that third one. Yes, there is actual data, but that's not so I want to, again, I'm going to separate you guys as the sort of peer leaders. There's the research and then there's the policy. The research absolutely says that 2 doses, a 0-6 schedule is very effective. And in fact, 0-12 might even be more effective. So that's a very exciting opportunity that we're looking at. But right now, the policy in BC, short of the school-based program, which you got, short of the school, you're giving 3 doses, and you are giving them, and if they are delayed, you just restart the series. You just restart the series where you left off. You don't start all 3 again. You just restart with that
And does that 2 doses extend to the 9-valent as well? Does it
So very good question about the 9. We are expecting to hear from Merck about the 9-valent 2-dose. What I did hear at the recent conference I was at was the guy who's the lead for the 9-valent study said we don't expect any surprises for 2-dose. What I anticipate that means is 2 doses in 9 for the 9-valent is going to be similar to the 2 doses for quadrivalent. Don't look at Bonnie, she won't give an answer, but that's what I suspect.
And it's safe in breastfeeding women, it's just not pregnant women we want
to use. Yeah, I can't remember if it's actually approved. It's not approved, no.
No, it's
so
not
you should just
approved
wait
in
till they've
breastfeeding.
weaned and then, okay.
Yeah, to finish feeding.
But it doesn't establish latency, so what would be the big problem in pregnancy? I know it hasn't been
There's
studied.
really no problem.
There's no problem.
There's no problem.
Yeah.
Like
Even
again,
in pregnant.
policy, science, right? So, but the policy is
And public image.
Okay, well, any WebEx? Not there has been yet, but
No, we have people there. Hi, WebEx, people from WebEx. Do you have any question? No. Okay. Thank you.
okay, well, thank you. Well, I'd like to thank Dr. Ogilvie and the rest of our speakers. I think it's been a really interesting morning. I certainly have learned an incredible amount. One thing, $50 million of BC taxpayers goes into HPV related diseases. And I learned that HPV can be under the fingernails. So I'm thinking that might be a way we can get people to vaccinate their kids, right? Oh, you can get it from holding hands. I don't know if that's true or not, but it sounds a little better. So we've got such a way to go, though, don't we? That the uptake of this vaccine is still way too low, and certainly the BC Pediatrics Society is strongly a proponent of a universal program for boys as well. We all need to be champions of vaccination, and this vaccine in particular, because of its controversy and the number needed to treat with this vaccine is better, or it's more important than meningococcal vaccine, for example. Your child, your patient's far more likely to run into serious grief from HPV, from meningococcal disease. Yet when our kids go off to college, we quite good about giving them every meningococcal vaccine there is, but we forget about HPV. Certainly my daughter got the HPV vaccine when she went off to college. But my son, well, that's another story, but I'm still working on him. But so anyway, I'm going to quote Anjali again. We need to be champions. We need to be a team. We need to be verbal. Every healthcare opportunity is an opportunity to discuss vaccination, and I thought her point of talking to the mom, talking to the sister, was a really good one, because we aren't seeing these boys that often in our practices. Be confident and be visible. So thank you all so much for coming, and to our speakers again.